Good afternoon and welcome to our second NorthShore Outcomes Research Seminar, the COVID-19 Research Series. Today we're delighted to be joined by Dr. Tom Gnatek from NorthShore University HealthSystem and Dr. Eric Luck from Swedish Government Hospital, who will be joining us to present the NorthShore Convalescent Plasma Collection Program, and Dr. Lucia Madriaga from the University of Chicago, who will be sharing her clinical trial insights from an ongoing study. Next slide. So I'd like to take a moment to thank the leadership at NorthShore University HealthSystem, our director, Dr. Bernard Eligman, the program directors in outcomes research, but also to thank the many first responders and those working on the front lines during the pandemic. I'd also like to introduce myself and Dr. Sean David. I'm a program director for translational science and outcomes research at NorthShore, and Rabia Ali, who is our research associate for outcomes research, who will be the facilitator today, and Rachel Brewington, who is the administrative assistant, who will be assisting us as well. So to those of you who are new to the seminar, NorthShore Outcomes Research Network was founded in 2019. It's structured with key academic leadership, providing support to really catalyze research across our university system, including the Institute for Translational Medicine, through a wider Chicagoland mission to improve population health. And our goals are to enable uniform community access to care that is effective, efficient, and equitable, enrich the practice of medicine for our many clinicians, and to support some key strategic clinical quality and operational decision-making. But the objectives of the seminar series are that we really want to have flourishing investigators come together and promote a culture of collaboration in team science, silo-free, and the ability to have a flat hierarchy where we can really share ideas and some exciting results and apply them. And we want to bridge people together through this seminar series, and that's one of our goals today. Ultimately, we want to deliver outcomes research that demonstrates improved patient and population health outcomes for our communities. Next slide, please.
Hello, everyone. I'm Rabia Ali, as Dr. David mentioned. And so in today's webinar, all of the attendees will be muted with the exception of our panelists and speakers. However, there will be some opportunity for interaction. If you have any questions or comments at any point during the presentation or the Incubator Hub discussion, please submit your communication by using the chat function as noted by the blue arrow on the screen. If you are on your computer, you can access that icon by just hovering your mouse over the bottom of your Zoom screen. And just please give special attention to the audience of your message before you submit it. As you can see to the image on the right, you can choose the message to either the panelists and speakers, and that would include myself, or you can message everyone on the webinar. And for the discussion portion today, to include everyone in your message delivery, that would be great so everyone can be involved. If you have any technical difficulties, please let me know by messaging all panelists, and I'll assist you the best I can. So I'm going to go ahead and hand it back to Dr. David, who will go over our agenda for today. Next slide, please.
Thank you, Rabia. So this is the outline of the agenda for today. The first 10 minutes is going over the process and the ground rules for how the Zoom webinar works. And then we will be following that by a lecture by the three investigators here today, Dr. Gnatek, Dr. Gluck, and Dr. Madriaga, for about half an hour, 3:10 to 3:40. We'll be having three integrated presentations during that time, a lot of content, but a lot of exciting results. And then that will be followed by a question and answer session. We'll be taking comments that will be introduced at the end to the speakers. And then we will follow that with what we call an Incubator Hub expert panel. So we'll have the speakers. We'll also be joined by Dr. Karen Call, who is the chair of pathology and laboratory medicine at NorthShore, as an opportunity to take additional comments and focus on 4 discussion questions dealing with health equity, dissemination science, policy, and future translational research opportunities. And then we'll have a few minutes for some closing remarks. Next slide, please. So I'd like to briefly introduce our 3 speakers today. Dr. Thomas Gnatek is the Assistant Director for Transfusion Medicine, Department of Pathology, and an investigator at NorthShore. Dr. Eric Gluck is the Director of Critical Care Services at Swedish Covenant, part of NorthShore. And Dr. Maria Lucia Madriaga is a thoracic surgeon at the University of Chicago, and she's an assistant professor at the Pritzker School of Medicine. Next slide. So without any further ado, I'd like to hand over the mic to Dr. Tom Gnetic and Dr. Gluck and Dr. Madriaga.
Okay, thanks, Sean. So back in March, the FDA, during sort of the beginning of COVID-19 spread in the United States, published recommendations for how people, whether that be a blood supplier or a hospital, might produce and use convalescent plasma for the treatment of COVID-19. Essentially, the guidance consisted of a few parts. On the collection side, the donor had to be qualified first as a normal blood donor. Now, the FDA did update their guidance on deferrals in early April in response to a potential massive national blood shortage, not just dealing with convalescent plasma, but because all the blood drives were basically canceled when schools and businesses closed during the beginning of the quarantine, we had a sudden drop in red cells, plasma, and platelets as well. So deferral periods basically shortened for things like exposure to blood or any other sort of potential prior exposure. It went down from a year or 6 months to about 3 months before you could donate again. The other thing for a convalescent plasma donor, obviously, is you want people who had COVID-19. And originally, the guidance was written that people had to be PCR positive and have record of that PCR diagnosis prior to donating, but then it was changed to include individuals who simply had a positive COVID-19 serology test. And finally was the concern, primarily from the FDA's point of view, I think, of COVID-19 being spread through the blood product. And so they at first said that a donor could donate after 28 days from symptom resolution. You could actually be a regular blood donor at that point. Or if you're between 14 and 28 days from symptom resolution, you could donate if you had a negative MP swab prior to donation, or if we did a PCR on the blood product and showed that it was negative for COVID-19 or SARS-CoV-2 RNA. And since nobody really validated blood product PCR, essentially the early days of convalescent plasma collection involved either doing NP swabs between 14 to 28 days, or like the major blood suppliers did, only collect from people who were beyond 28 days. And then just to sort of give you the theme, things changed and the FDA eventually said anybody past 14 days could simply donate without an MP swab. Now, once you collect the plasma, there were 3 avenues for using it. You could submit an IND to the FDA as part of the beginning of a clinical trial. And this would be similar to any drug investigational trial where the FDA would have to approve the entire protocol from collection to usage and give you sort of a blanket approval to use the product for anyone enrolled in your study. The director of CBER also went to Mayo, I hear because he knew people there, and started an expanded access program which was run essentially by Mayo with funding from BARDA. Hospitals and individual providers could sign up for the expanded access program. It was not a randomized controlled trial at all, and like all expanded access programs, the intent initially was to have it be a stopgap, only for people who would be not eligible or unable to participate in a randomized controlled trial. The third avenue was actually sort of a standard single patient emergency IND, where you would call the FDA prior to transfusing and you would get approval for that individual patient. So I'm going to talk a little bit more about the expanded access program. Basically, the initial thought was that a couple thousand people would get of convalescent plasma under this umbrella. It grew eventually to over 50,000 people receiving convalescent plasma across the country. It is single arm. Institutions that transfuse the plasma could report data back to Mayo or not. And there was no requirements to test the units for antibodies against COVID-19. It was just, a sort of rapid effort to transfuse plasma from people who had COVID and recovered. Now, this all sort of got into the press in March. There were a couple papers published speculating on how wonderful convalescent plasma would be. And next slide. And basically, NorthShore sort of made an institutional decision to invest in the ability to collect convalescent plasma. And this is in the backdrop of the national blood suppliers at that time not having nearly enough convalescent plasma to go around. So NorthShore has a blood donor center. We've been collecting whole blood and apheresis platelets, as well as autologous peripheral blood mononuclear stem cells for years, many years. We just basically never closed it down from 100 years ago. So we ordered 2 plasmapheresis machines in early April, and within about 2 weeks, we had our staff trained and began our first collection, which was really unprecedented for us. It was a huge amount of effort by the donor room staff and the transfusion services to write all the procedures and do the training. The instruments themselves allowed us to collect essentially just plasma from donors. And we would get 3 units or 3, 200, 220 cc doses of convalescent plasma per collection. And so here you can see the, bag 1, 2, 3 hanging on the machine. The procedure itself would last about an hour. And if you donated every 28 days during non-COVID time, that would be fine. If you donate less than every 28 days, you would be considered a frequent plasma donor, which is fine, but there's certain things that you have to do to monitor those people's health. During COVID time, us and the larger blood suppliers basically notified the FDA that for a certain amount of time, we were going to collect people at most every 2 weeks. And so a donor could come and donate essentially 6 units a month as part of our program. This was all done under the auspices of a research study. And the aims of the study were sort of broad. Obviously, it was to collect the plasma quickly and efficiently. We were very concerned initially about protecting the donor room staff from COVID-19 exposure. And I don't know if everyone remembers, but back in, let's say, March, people were not wearing masks and were maybe even not allowed to wear masks because there was a concern of mask shortages. And here we had people who had COVID, whose infectious potential was really unknown at the time, coming in and getting hooked up to a machine by someone that has to get very, very close to them in order to perform the phlebotomy and operate the machine. And so we were really worried about sort of propping up this wonderful system and then have it be curtailed by the potential of a COVID-19 outbreak among the donor room staff. Obviously, we're also interested in what donor characteristics correlated with high titer antibodies. And because of that initial guidance about doing NP swabs, we started doing NP swabs, but then we thought, well, it'd also be interesting to know if there's a relationship between people who, let's say, stay positive for a long time by NP swab and other people who are negative very quickly after they had COVID to their antibody titers. With all the plasma, obviously we would be well positioned to study our serology platforms and sort of evaluate the sensitivity of the commercial serology tests for SARS-CoV-2. And we also are interested in what's known as neutralization titers, so the ability of the antibody to prevent virus from entering into a cell line and infecting that cell line, which could be different than our commercial serology platforms, which are mostly simply binding assays that look at the ability of antibodies to bind to the virus. Next slide, please. So the protocol was set up where donors contacted our blood bank, we called them back, and on that initial phone call, we got their history in terms of when they had COVID and when they recovered, sort of discussed with them the eligibility criteria, sent them the consent by email if they were amenable to that, and then had them come in for a visit. Now, the way we set this up initially, people clearly wanted to donate, and they wanted to donate the day that they came in, and so that's how we ran this. Unfortunately, then it became a big day. So in the beginning, they went to the outpatient lab at Evanston Hospital, again, out of the fear that they may be infectious. We had a room that was dedicated just for these consents, and the room had to be sterilized, or not truly sterilized, but treated with alcohol in between each person, and that created a bit of a bottleneck. And so within a week, we moved to the Evanston Hospital ED that had converted an ambulance bay into a large negative pressure area with various booths that were initially designed to evaluate potential COVID cases. And because they weren't necessarily used as much as maybe was feared they would be, there were many booths available for us to consent these donors. So they would come in and fill out a COVID history form. We did an MP swab screen, and we used the Abbott ID Now, which was actually located up in the micro lab. And then we brought them down if they were negative by swab to the donor room, which was in a conference room. We basically expanded our donor center and took advantage of the fact that there were no more in-person conferences. And then you had to go through the normal blood donor screening and the donation. So logistically, setting something like this up in a matter of literally 2 weeks presented sort of a challenge. NorthShore obviously has research staff and research coordinators who do an excellent job, but it literally felt like building a plane as the engine was revved up on the runway and hoping that we would take off before we get to the end of it. And so essentially, Dr. Call allowed me to begin recruiting and consenting, and the donor room staff were motivated and pivoted from collecting whole blood like they normally do in platelets to collecting convalescent plasma. And so the first 3.5 weeks was sort of a breakneck pace, recruiting people, getting them down into the donor room, going through the consenting process as quickly as we could. And just to give you an idea, when we began collecting it was around the 15th or 16th, we sent units to Swedish Hospital within a day of when we had the donor infectious disease testing back. The demand was just, off the chart at that point. And it wasn't really until the end of April that our inventory sort of stabilized. And by early June, we actually faced another problem, which was our freezer was full as the case count sort of dropped and the use dropped with it. And next slide. So just to give you a sense of who it was that we had coming in to donate, this is the days from symptom resolution to when they came into consent. And as you can see, early in the epidemic and our collection program, most of our donors had recovered from COVID in the prior sort of 3 to 4 weeks. But then later, we started getting people who had COVID weeks and weeks before. Most of our donors were middle-aged on average. It was a pretty even breakdown between male and female. A very small percentage of them had been hospitalized, perhaps not surprisingly at that point in the epidemic in this area. And given the way that testing was prioritized at that time, we had very few asymptomatic folks. So essentially 97% of the people had COVID-19 symptoms. Sort of a depressing thought when you go through your temperature screening, only about 40% of them reported ever having a fever with COVID-19. Next slide, please. And give you an idea of how it went, we ended up taking in about 300 donors within the first 100 days of the program. And of those 300, about 60 to 70 of them ended up having some issue, whether it was an initial deferral for either a low hematocrit, low body weight, a medication or medical history that disqualified them from donating blood, or we also tested for anti-HLA antibodies to prevent trolley, but we did that after the collection. So we lost a number of units with the fact that they were anti-HLA positive, and we couldn't give them because of trolley. Of course, we used them for research. The other thing is that we did have a number of donor reactions. So about 42 of our collections yielded essentially no product at all, whether that was from a vein infiltration or a vasovagal reaction. Most of our donors came in once. There were just a few of them that ended up coming in more than once. Now, once we got these products and all these samples, we started testing for antibodies. And so this is just to show you one of the comparison studies that we did, looking at 4 of what was for us readily available serology tests. 3 of them were in-house. The Beckman is an anti-receptor binding domain, which is a portion of the spike protein. Diasorin's assay is a total spike protein target. Roche is it's actually the nucleocapsid. It's a different protein. Roche's assay is IgG, IgM, essentially anything that cross-links nucleocapsid. And Genolite is a company, folks that Sean David knows, where they have a multi-target assay that looks at IgG and IgM. And what essentially we showed was that the sensitivity is pretty good for these tests. It's not 100%. And for the ones that dip down around 90%, which is lower than they reported in their EUA data sets, the difference may have to do with the fact that people who are very, very sick with COVID tended to have higher amounts of antibodies. And when they validated these assays, they tended to use samples from hospitalized patients, not samples from people like our donors, who basically only had COVID for a day or two, or they were never hospitalized. Now, if you look at the histograms, so basically on these assays, about 50% of people had what we would consider high binding, and so the x-axis is actually a signal over noise sort of quantitative readout for all these assays. Interestingly, the Roche was consistently showing a bimodal distribution, although it wasn't clear exactly what this was. There was a relationship between the time of symptoms starting and sample collection that seemed to correlate with that right-sided sort of peak in the Roche histogram. But as we've gone forward, we've basically tried to select donors who are in that top 50% on these binding assays. We also collaborated with a lab at University of Minnesota that did true viral neutralization titering for us. And so essentially what they did is took live SARS-CoV-2 virus, added GFP, and then they would infect a cell line and look for GFP expression. So it's slightly different than a plaque reduction assay. They would add different dilutions of plasma from a single donor. So like each of these black dots is from a particular donor at different dilutions, and you end up getting a point of 50% inhibition. And so for donor 63, it's 1,322 is the NT50. And I just wanted to show this because there is a wide variety of neutralization titers from one donor to another. And so immediately a question came up, which was, what's the relationship first among the different binding assays, but then also between binding assay and neutralization? So if you compare the binding assays themselves, there is a correlation. It's not great. I mean, there's for sure outliers when you do 2x2 comparisons, samples that have very high on one binding assay and very low on another binding assay. And if you add in, so NT50 is the neutralization titer, what you can see is that the Spearman correlation, it's positive, but it's not 1. Another way to look at this, if you go to the next slide, was to break it down into tertiles. So if on the x-axis, the binding tertiles, and then on the y-axis is the neutralization, that 50% inhibition titer. And what you could see is if you're in the upper, let's say, third of the population for Beckman or Diasorin or Roche, you do tend to have a higher NT50. But again, there are outliers. There's samples that have very high binding with very low neutralization, sort of duds, as Eric might call them. And this is just another graphical representation of this. So again, if you're in that highest tertile, you've maybe got a 75 to 80% chance of being in sort of the upper half of neutralization strength. Next slide. And the other thing we looked at, obviously, was correlations between binding strength of these antibodies and people's history. And essentially what we saw was that if people were hospitalized or they got treatment, which could have been as simple as Tylenol, they tended to have higher binding antibodies. And that was true for the anti-nucleocapsid antibodies on the Roche, and it was also true for the anti-spike antibodies. The other things didn't really pan out, and we were very careful because we were doing a lot of multiple comparisons, so we sort of adjusted the p-value appropriately. And do next slide. But here's just an example where we looked at fever, no fever, and this is now with truly the neutralizing titer. And again, we saw sort of a correlation maybe with age, but once you start correlating, or once you start doing t-tests on so many different parameters, that p-value of 0.05 no longer necessarily is significant. Next slide. In terms of NP swab positivity, so it was a little bit sobering. Essentially, we had around a 10% positivity rate if we swabbed everybody who came in greater than 14 days from the resolution of symptoms. And it sort of drifted down. It drifted down, and it wasn't until around 49 days that it really started to drop off. Next slide. Sorry, next slide. Thank you. And also, we saw a hint of maybe a relationship between loss of taste and smell and NP swab positivity, and maybe a inverse relationship between diarrhea and NP swab positivity, but nothing was really statistically significant. So, in conclusion, more severe disease seemed to have higher binding antibodies. A lot of people were positive by NP swab greater than 31 days. And we do see a correlation between neutralizing antibodies and binding antibodies, but with many outliers. Next slide. I just want to follow or sort of end with this. So the Mayo Expanded Access Program recently sort of disclosed data. They're trying to show some amount of efficacy, but they don't have a control population. So they looked at recipients who got plasma with high binding antibodies versus low binding antibodies, and they looked at time from getting symptoms to getting the plasma. And what they saw is that if you got the plasma less than 3 days from diagnosis, you had lower mortality, or your rate of death was less. Next slide. And if you got high binding plasma, you did better than if you got plasma that had low binding antibodies. But of course, those confidence intervals are coming really close to 1 there. All right, next. So NorthShore joined 2 outpatient convalescent plasma trials. We did get funding as part of that to continue collecting. The DoD is interested in stockpiling, and the FDA now is talking about issuing an emergency use authorization for convalescent plasma. Rumor has it that they're going to say it needs to have high antibody reactivity. Next. And I just want to thank really a massive group of people who have made all this possible and worked incredibly hard to do it.
Thank you, Tom. That's great. Dr. Gluck, would you be able to? Okay.
Yes, thank you. It's a pleasure to be here and to show you our preliminary analysis of our data in using convalescent plasma. You can show the first slide, please. Next slide. Okay, so this is not a new idea. Passive immunity has been known to occur for over 150 years. The first major attempt to do it clinically was in 1918 during the Spanish influenza. There were two other attempts during the MERS and SARS-1. The MERS and SARS-1 sort of faded pretty abruptly, and so there wasn't a lot of experience, although the experience that was present was positive. There was a lot of experience from 1918, interestingly. The unfortunate thing was that it wasn't very quantitative. It was mostly empirical and observational. But there was one key aspect of the study which we got our hands on and read from 1918, and that was the conclusion that the earlier you gave the plasma, the better the results were for the patient. The Mayo Clinic study that we had hooked up with had a relatively late start for administering plasma to patients, although it was a bit vague, and we sort of interpreted it so that we could get it to the patients a little bit earlier than I think most people did in other centers in other regions of the United States. Our biggest problem was we came up with this idea and there was no plasma yet because we did not have enough COVID survivors to identify. Fortunately, Swedish hospital was in the right place at the right time, joining forces in the NorthShore University system with a system that had the ability to obtain a tremendous volume of plasma relatively quickly. The second problem was that we were sort of flying a bit blind. We were unable to get high sensitivity and specific antibody detection. And so we were limited to qualitative identification of plasma that had antibodies, but we weren't sure about the quality of those antibodies. And that did cause us to change the way we did our study a little bit later on. We did join up with the Mayo Clinic, but we also had our own IRB-approved study, which helped us administer plasma a little bit earlier than in some of the other regions, as I said. Next slide, please. So I guess you probably know who we are, but we're part of NorthShore. We're about 350 beds. And the biggest asset that we had at this point in time was being able to tap into the source of plasma from NorthShore. Next slide, please. Our hypothesis was earlier use would result in improvement that was significant. Waiting until the patient ended up in the intensive care unit on the ventilator was what people were doing at the time, but we felt that this would not be a very good idea. We evaluated different endpoints for our study. We looked at X-ray appearance, levels of oxygenation, and the inflammatory markers that had been identified early on from China. So the Chinese investigators looked at the dimer, LDH, CRP, and ferritin, and found these inflammatory markers to be markedly elevated during the acute phases. What they hadn't told us was that there was no real correlation in the regression of these markers with outcomes. So in addition to those, we looked at hospital length of stay, need for an intensive care unit, ventilator length of stay, and mortality. Next slide, please. So the population that we studied were basically all the patients who were admitted to Swedish hospital who are documented to have COVID-19. In order to be admitted to Swedish, you needed to have a saturation less than 50% from air, or obviously any more rich supply of oxygen. In our thing that differed in our study compared to many of the others was that we considered severe cases of COVID in patients who required 5 liters nasal cannula or more in order to maintain a saturation of 93%, which basically got patients into our study a little bit earlier than in some of the others. Informed consent was obviously obtained in all the patients. Next slide, please. As I alluded to, we measured ferritin, LDH, D-dimer, CRP, and procalcitonin. We were not excited about any of the information that we were able to obtain either as a trend or individually from any of the markers except for the D-dimer and procalcitonin. All the patients who received plasma were pretreated with Lasix, Benadryl, and Tylenol. Now, our first 20 patients only received one, unit, or about 200 mLs of plasma. In the rest of the patients, after the number 20, we gave 2. And the idea here was not that we thought we needed necessarily more antibodies. We wanted different antibody donors, such that if one of the donors tended to be, as I like to call it, a dud, meaning not having good neutralizing antibodies, then we might obviate that by having 2 different donors, decreasing the likelihood that both of them would not be good donors, and therefore the patient would get benefit. So once we had enough plasma to donate, to deliver to patients, we used 2 different donors. So we never used the same donor on an individual patient. They were always different donors. In addition, we got chest x-ray, blood gases, and the other inflammatory markers. Next slide, please. So we divided our patients into 3 groups for analysis. We noticed right away that there were some patients who all 3 different domains improved. Oxygenation, x-ray appearance, and inflammatory markers decreased within 48 hours of administration. We also had partial responders in which not all of the different domains improved, but at least one of them did. And then we did have a group of patients who did not respond at all, that despite receiving the plasma, there was no improvement in oxygenation, chest x-ray, or inflammatory markers. Next slide. And interestingly, in the first group of 60 patients, it was about 33% for each of the groups. Next slide. During this trial of the first 65 patients, we did not have any episodes of Trali or Taco. However, we have subsequently had one donor who actually gave Trali to 2 separate patients about a day apart. And that was a patient who was, if I'm not mistaken, HLA antibody negative. We've had some febrile reactions, but in this patient population who have variable fevers from the onset of the illness to several days and even weeks into their illness, it was difficult to know whether they were related, in fact, to the infusion or not. We did not identify any patient who developed cytokine storm in relationship to receiving any plasma. There was one patient who we only gave 1 unit to because the patient was oliguric and we were afraid of volume overload. Next slide. And these are our results. In our pre-convalescent plasma group, there were 32 patients. And we organized our data based on where we got the patients from. Obviously, patients who went from the emergency department directly to the ICU were going to be patients who received convalescent plasma very late in their course of illness when they were already very ill. So we were really concentrating on the patients who were admitted to the floor, gradually deteriorated, and then required intensive care unit admission. And these patients we were often able to see progress from requiring either 2 liters all the way up to 5 liters, at which point in time we gave them the plasma, so when they reached 5 liters nasal cannula. And so you can see the distribution here was about 2/3 of the patients who went to the intensive care unit actually were admitted directly to the floor, then deteriorated on the floor and ended up in the intensive care unit. And about 1/3 of the patients ended up directly from the emergency department going to the ICU. There was a big difference once we started transfusing patients with convalescent plasma. Most of the patients, 1/3 of the patients still came from the emergency department, but patients who received convalescent plasma, only 13 of the 77 patients who received convalescent plasma ended up requiring the ICU. All the other patients who ended up going from the floor to the ICU did not receive convalescent plasma. So one of the major identification of benefit that we saw here was a reduction in the need for ICU resources and basically preventing our system from collapsing under the weight of this. Next slide, please. When we actually looked at the other outcomes based on whether the patient was a responder, intermediate responder was the one who responded to 1, 2, or 3, or 1 or 2 domains, and the non-responders did not respond at all. You can see that there was very significant changes in the ICU length of stay, the average vent days, and the mortality rate, which was the most significant. You can see that the non-responders basically had a mortality rate that was very similar to what was reported in New York during their severe surge where they were where the system was overwhelmed. But the patients who responded in all 3 domains had a mortality rate of only 8.7%, and those who responded to 1 or 2 domains had an intermediate mortality rate, but actually closer to responders than non-responders. Next slide, please. So what are the limitations of the study? These are just a couple of them. There are more that we could talk about. Obviously, this is a pandemic, and there is no other therapy that we could verify this against. So we really only had historical controls. We used the historical controls from our hospital, but even so, I'd like to think that we got better at treating these patients once they got to the intensive care unit as time went by. So there was a moving dial here as far as the historical controls. There were additional therapies that the patients received. The first bunch of patients were still getting hydroxychloroquine and zithromycin. That stopped after about 15 or 20 patients went in a study. We decided not to do that anymore. But as the study progressed and we became one of the centers that received remdesivir, virtually every single patient who got plasma once we had remdesivir also got remdesivir. And of course, the most important thing is we didn't know the potency of the convalescent plasma. So difficult to know whether the patients were responding on their own or whether there was an inherent difference in the neutralizing antibodies in the patients who had vigorous responses from those who did not respond at all. Thank you, and I think that is my last slide, and at this point in time, I'll turn it back to the host.
Thank you, Dr. Glockner. Brilliant work, and I will hand over the mic to Dr. Madriaga. Okay. Lucia, you're on.
Can you hear me?
Yes.
Okay, so I'd like to present our University of Chicago experience. Next slide. So similar to all the
people who have told us this morning. This is our timeline of events, and as you can see, it's a pretty quick timeline, as everyone experienced that we really want to get a convalescent plasma project up and running, and we had a lot of great people working with us so that we could get IRB approval quickly and that we can get our first donations in by April 16th. In our hospital, we did have quite a fair bit of COVID-19 patients, and we were able to treat our first 10 patients 4 days later. How our program differed from NorthShore and Swedish was that we used whole blood donation at the blood bank instead of plasmapheresis. And we decided that for the safety of our donor blood bank that we would only use plasma donors who are 28 days after symptom resolution. The way we set up our study was that everything was electronic. Our IRB had not previously been very well experienced in electronic consenting, but with COVID-19, everything rushed to the electronic platform. So everything was in red caps. And in a single phone call encounter or people fill out surveys online, we were able to elicit donor symptoms, donor past medical history, and then consent them for the blood bank for blood donation, and as well as schedule them for a blood bank appointment. Next slide. So this is just a simple slide that demonstrates what other people have spoken about before, that there was a very wide variability in donor antibody, anti-RBD, and anti-spike among all the patients that we tested. And this represents the first 105 plasma donors that we tested. We had 2 plasma donors that had neither anti-RBD and anti-spike, and 2 others that had either no RBD or no spike. Next slide. We did a multivariable regression analysis based on the intake history that we performed via the surveys, on electronic surveys, to decipher which factors may be predictive of higher antibody titer. I think that's a useful thing to understand because in some countries they might not have as much testing capabilities that we do, and so reliance more on medical history, infection history, and time since infection might be very important. And what we found among our segment of plasma donors was that age, advanced age, fever, absence of myalgias, fatigue, blood type, and hospitalization were actually correlated with higher anti-RBD and anti-spike. Next slide. This is a graph that depicts the clinical course of the first 10 plasma recipients who we transfused in our study. We did not experience any side effects in these first 10 recipients. We did not pre-medicate them. So they basically received plasma as basically part of their ICU care. And you can see that 2 of our patients were on ECMO, and the black line that bisects the screen at time 0 indicates the time of plasma donation. These 2 patients received plasma and unfortunately did not see any clinical improvements. Probably this is because they are too far along in their disease course. As you can see, that they had the longest length of time of the disease course on the left of this black line that bisects the graph. And they both died in about 30 to 32 days after receiving plasma. The rest of the 8 patients who initially received plasma at our hospital ranged from being on the ventilator, needing high-flow nasal cannula, being on nasal cannula, or on room air. They received plasma and they recovered from COVID-19. They were all discharged. We had 2 patients who were immunosuppressed and received plasma because they were not able to receive other therapies. One was a previous lung transplant recipient who came in with fevers and acute renal failure from COVID-19. And another was a bone marrow transplant recipient who also got plasma. Both of these patients received plasma with no side effects. Next slide. And this is my final slide because I want to save more time for discussion. But basically, these 4 graphs depict what we analyze as the antibody response in the plasma recipient. So we were able to collect data, antibody titers before and after plasma transfusion. And as you can see, all the patients who were not on ECMO had a consistent increase in antibody levels after plasma transfusion. It was kind of strange in the ECMO patients that we actually saw a decrease in antibody titer levels, and I'm not sure exactly why that is so. They also happen to have the highest levels of antibody titers among the initial cohort. Currently, we are still collecting plasma for our patients in the hospital and using the same criteria that we had established at the beginning. But our mechanism for giving plasma to patients is now through the Mayo Expanded Access Protocol. So it's much more readily accessible to every person in the hospital to do so. Next slide. And I just want to highlight what other people have highlighted before, that this kind of endeavor of giving convalescent plasma requires a lot of logistics, please press again, and teamwork among, next slide, among lots of different people. Click. Excellent. It was animated. And so basically, we assembled a great group of people all throughout the hospital and university in order to study convalescent plasma and in order to make this program happen. Actually, because during that time, all elective surgeries were kaput, the donor team, the people who recruited patients, scheduled their appointments, and got everything up and running were all surgeons. And then we collaborated with our inpatient ID and medicine teams to just coordinate the recipient side and decide which recipient should get plasma, especially in the early days when we didn't have enough units to go around. And we partnered up with Patrick Wilson Lab, who is an antibody specialist, and of course our friends at the blood bank to help us get all of this up and running. So thank you, everyone, and I'm done with my portion of the talk.
Thank you all very much. Just an amazing mobilization of great research and patient services. I'm going to hand this over to Rabia to manage the question and answers.
Yeah, thank you, Dr. Gneidick, Dr. Gluck, and Dr. Madariaga. These projects you are working on are so captivating, and it's truly impressive how much you've accomplished during this pandemic. So I guess we can take a few minutes to take some questions from our listeners. And as I stated earlier, you can input any of your questions in the chat box by addressing it to panelists and attendees so everyone can be involved. And if all questions are not addressed, feel free to contact our presenters. I have placed the emails on the screen here. So I guess I can give a few moments for everyone to kind of type in their questions and our presenters can answer. And then after that, we will go into our Incubator Hub discussion.
I have a question for the presenters. Is it your sense that we have enough reliable biomarkers to predict convalescent plasma response, or combined with certain historical factors where an index could be developed to identify patients likely to respond?
We had none. The Mayo Expanded Access Protocol did not require, or I think even include, testing of the recipient prior to transfusion to see if they were negative for antibodies before they got plasma. I do know from testing we've done that many patients who are in the ICU at around days 7 to 10 into their symptoms are positive for binding antibodies against COVID-19 on their own.
We also did not find any specific pattern of biomarkers that were present before the patient received plasma that actually predicted success either. But we are doing a more sophisticated evaluation now to see if maybe we missed some subtle changes. But we were flying blind. There were none of the expected biomarkers that we were looking at actually were predictive of response nor predictive of outcome.
So there is a question here in the chat for Dr. Gluck. Was there a difference between plasma recipients who did and did not receive remdesivir?
No, we were actually, well, once we got remdesivir in-house, we were one of the centers that got a very nice amount of medication to distribute to patients. And so basically all of them met the same criteria that they would have met for the plasma. So the only thing that differentiated the two was the willingness of the patient to accept it. And we did have about a 20 or so percent refusal for plasma transfusion in the patients in whom we wanted to give it to. And that did make up a significant portion of the patients who were on the floor and ended up in the intensive care unit who did not receive plasma. So a lot of the patients refused it. But other than that, the criteria were exactly the same. And the fortunate thing was that neither the Mayo Clinic study nor the remdesivir study would disallow a patient to receive both therapies.
Got it. Okay. And so I see another question here for all of our presenters. From what you have learned, what advice would you give to clinicians if there is another wave of infection?
At this point in time, I think there is enough evidence that plasma is beneficial. To what degree is yet to be determined. I believe that earlier therapy is more successful than waiting for the patient to significantly deteriorate.
I agree as well.
Sometime. At the hydrant.
All right. So if there aren't any more questions, we can move on to the next slide. Dr. David can introduce our expert panelists for the discussion.
Thank you very much, Rabia, and thank you again to the speakers today. So I'd like to reintroduce two of the panelists, Dr. Eric Gluck from Swedish Covenant Hospital, and Dr. Lucia Madriaga from the University of Chicago. Also introduce Dr. Karen Call, who is the chair of the Department of Pathology and Laboratory Medicine at NorthShore, and a clinical professor of pathology at the Pritzker School of Medicine at the University of Chicago. Next slide. So as part of our expert panel process, we'd like to discuss 4 discussion points. And the first of these is, what are the implications of this research, all that we've learned about today, for health equity? And we welcome any of the panelists to comment on that. In particular, Dr. Gluck and Dr. Madriaga, if you could comment on the health equity implications of convalescent plasma access and some of the results of your research.
You know, we were in the right place at the right time for our patient population. Swedish Hospital is a safety net hospital. It was not very long into the pandemic that our ICU was full and our accessory ICU was filled as well. And during the vast majority of the time, the patient population was Hispanic. There was a time actually where we had 28 people on ventilators, all of whom were Hispanic individuals from the neighborhood. And it was fortunate for us that we were able to get sufficient quantities of plasma to distribute to all these patients. Now, there's lots of reasons why it turned out to be a disease primarily in our neighborhood, Hispanics, based on their fact that they were essential workers. They could not work from home. There were multiple generations living together in the same family, in the same home, and other issues as well. But it did seem in our neighborhood to adversely affect patients of lower socioeconomic status more so than the higher socioeconomic status. And like I said, we are looking at our data almost specifically to look at the experience from a Hispanic perspective, as well as from a perspective of using convalescent plasma.
Yeah, and likewise, here at University of Chicago, a lot of our population is from the south side of Chicago, so predominantly African American. And I think one of the greatest barriers that we encountered was, even though the doctors would recommend trying plasma, there was a fear of going on a clinical trial. And that is a fear that's based on past history of patients being admitted to University of Chicago and not being well educated about their choices. And that we have been working with the community to improve our communication so that people don't feel taken advantage of or experimented on in the hospital. But certainly early in the days of the pandemic, there were several patients who we felt would have benefited from plasma, but they didn't want it because they thought it was experimental.
I'd have to echo that. We found a similar thing, given the fact that at that time, when we started doing convalescent plasma transfusions, there was no other therapy that had been demonstrated to be beneficial, and this seemed to have the best chances for improving outcomes. We still did get a lot of negative responses to being in the trial. There was some language barrier difficulties explaining what we were going to do and why we were going to do it. And often we were unable to explain it directly to the patient because the patient was hypoxic or ill from with other things, electrolyte disturbance, acidosis, and things like that. And so informed consent was actually gotten from a surrogate. But as I stated before, about 1 in 5 of the patients actually refused to participate.
So I've got a question from the group. You've all presented some really compelling and exciting data. If we do have I don't know if we're out of the first wave or into the second, I don't know where we are in the course of this pandemic, but do we know enough now that we can say this has become standard of care with the data we've got? And then as a follow-up, do we have societally enough convalescent plasma collected that we can use it broadly? And is there a network for disseminating plasma across the United States in areas where it's needed?
Well, I would say that we are close to being able to say that this could be standard of care. I don't think we have analyzed enough information. Certainly our center, our data would be very compelling, but it is only 80 patients, and it is a single center, and it was not a randomized controlled trial. So I think we're close. I think that the experience across the country has been similar. I think our experience was a little bit better than some of the others that have been reported, only because we used it earlier in the course of the illness than other people did. So it'd be nice to be able to separate out that data in other centers and see if that trend continues. I think that one of the problems that I saw in Chicago, and probably is prevalent everywhere, was there was not a lot of crosstalk amongst the hospitals during this pandemic, trying to maximize resources across the greatest number of critical care beds, and so there was disparities in, I was sitting in the right place and I got more plasma than I ever would have needed, while there were probably other centers in Chicago that didn't get plasma because they didn't have the mechanisms to obtain it. The same thing was true with other drugs as well. It wasn't just the plasma. Remdesivir, there was a long waiting line before people got their hands on that, and was never really sure about what the mechanism was for distributing that medication. I know that it was in some regards based on how many cases you saw. But I do think that we could do better as a healthcare system if we work together and distribute excesses to places that are missing things and vice versa.
Yeah, I totally agree. And I think another thing that brought out health disparities and access is that we had so many COVID-19 trials going on at U Chicago. We had remdesivir, high dose, low dose, blah, blah, blah. We had tocilizumab. We had, all these other, azithromycin, like that. We had so many trials, and a lot of them competed for the same group of patients, unfortunately. And there was, at the beginning, no good way of saying which patient gets this therapy versus not. And the way that harmed the patient was because if you were, for example, on the initial remdesivir trial, you were not allowed to have plasma therapy. So we basically had to get patients who were not, went through all the other trials and then were able to get plasma without interfering everyone else's trial. So I think for me, a lesson going forward would be to think about the hospital as a whole, like the scientific community, the clinical community, of how to organize all these trials. Because it's great that we have all these choices, but then we need to figure out which patient is best served by which trial. And all those criteria and algorithms that we have now in place, it took a little while to get it going.
Mm-hmm.
Yeah. And also, just a question for Dr. Call, too, whether or not departments of pathology across Chicagoland are coordinating with, say, redistribution of plasma, which a lot was banked at NorthShore, whether there's a plan for a system.
Yeah. So when it comes to distribution of plasma, I'll defer to Tom. What I will say is there was tremendous communication across the country, quite honestly, through a couple of very active listservs with respect to getting everybody up and running to develop and implement testing. And that's really where my expertise is. Our lab here and many others helped each other out and shared materials and have even shared materials during our supply chain challenges in the last few weeks. So there's an ongoing coordination of efforts with respect to the testing. Not all the answers, but at least a lot of communication. Tom, I don't know what you've seen with respect to distribution of plasma and sharing in that area, if that's the same dynamic or not.
We actually did some of that in the Chicago area for hospitals that reached out to us early on, especially when the major blood suppliers didn't have plasma available. And I don't know what will happen if there is an emergency use authorization. My concern is that now there's a lot of potential donors, but not all of them have high titer antibodies. And if the EUA goes through saying that it's the high titer units that qualify, suddenly we could be back in a situation where we have very few qualified donors. And if the cases rise, we'll have higher demand than supply again.
Mm-hmm.
We can, just as a point, we can ship plasma nationally as long as it stays an IND product and the recipient institution has an IRB approved protocol.
So thank you very much. I think this segues into the next question about the implications of this for healthcare dissemination and implementation science in the future. And there's also, each of these institutions have convalescent plasma clinical trials. NorthShore has two as part of a Hopkins multi-center trial, and Chicago, I'm sure the other institutions do as well. But in terms of all these critical questions of how to implement, provide equity and availability, and also equity across the region, I wonder if Lucia and Tom could talk a little bit more about that going forward, what needs to happen.
So I think there are efforts by certain institutions and sort of nonprofits to organize people who, either had COVID-19 and recovered or have just been diagnosed. I know that there's Facebook groups, there's online websites to try to organize potential donors. And I think, and we had a religious group in the area organize to promote people to come and donate convalescent plasma. And I think those efforts should be strongly encouraged if we need more convalescent plasma donors in the future. I think they're incredibly effective.
Lucia, you're muted.
Oh, sorry about that. I think that, yeah, these forums and others like it are very good for sharing information, and perhaps since we are at a steady state now, we should make some plans for if a next wave happens. Because certainly what we were experiencing as well was that a lot of patients at other hospitals or family members were calling us asking, can we transfer, can you give us plasma, can we give us plasma? And early on in those days, we didn't have those capabilities of transferring or giving plasma units away.
It seems like a very important area to have some kind of standard or harmonization across institutions so that it's built into formularies and standing protocols and some kind of integration the way that hospitals and ambulances do in the city going into the next potential spike in the pandemic. Very good, thank you. So the next discussion question is, what are the implications of this research for health policy? And in particular, Tom and Karen, I wonder if you could respond to the health policy implications.
I'll just comment. I think one thing about the Mayo-led expanded access protocol has been that we've used convalescent plasma on an enormous number of recipients without clear data showing one way or another, in a randomized control study to either show safety or efficacy. One problem that we have is some of the randomized control trials that are going on are using plasma from people either prior to 2020 or plasma that's tested negative for antibodies against COVID-19 as the control arm. And we know from other studies that transfusion of plasma itself, even without any anti-COVID antibodies, has effects on the immune system and other effects on the complement cascade and obviously the coagulation cascade. So it's not clear to me that we, even in the medium term, will have clear data with a true control cohort. And I think from a policy perspective, the question then becomes, in the setting of a pandemic, what are we comfortable with? And where do we draw the line in terms of offering patients the autonomy to make a choice about receiving let's say, unproven therapy versus an institution making that choice?
So Tom, I'll ask a question back to you, since this is not my main focus in practice. I'm much more grounded in the molecular world, where we are dealing with lab developed tests and the FDA coming in and often battling for reimbursement. But in terms of policy, I believe that plasma is now given as an IND. Blood banks are regulated by the FDA, so we've got some similarities there. But is this being reimbursed? Is this going to be at some point written into standards, consensus guidelines for caring for these patients and so forth?
So in terms of reimbursement, the expanded access protocol, in theory, is covered under funding through BARDA. And it's not like you're getting reimbursed from an insurance, but it's sort of a wishy-washy funding source, because initially they were going to reimburse the hospitals, and then the blood suppliers started billing the hospitals, so they were going to reimburse the blood suppliers. Right now, if you want money from BARDA, you have to agree to data sharing with Mayo in such a broad manner that it's not clear that our data governance folks would agree to it. And as an IND product, you're absolutely right. You can't bill a private insurance for the use of the product. I don't know what happens if the emergency use authorization goes through.
Mm-hmm. Okay, so that'll be interesting in terms of policy to track that and see what happens. You know, I was going to make a little bit of a tangential comment, you know, as a department chair and wanting to support, you know, programs like this where we've really got some, again, phenomenal data, and I've appreciated the presentation today. But, you know, how do we get this off the ground from the standpoint of, you know, working within a healthcare system? And I think, you know, we were able to justify the purchase of the instrument, you know, fortunately, because as Tom pointed out, it was going to be used for other things down the road. And so we'll, you know, this is a point in time where we'll be using these collection instruments for COVID and plasma, but eventually we'll be able to, you know, streamline these into our donor collection services in the blood bank. And so that, you know, made it easy. We've also cultivated a relationship, which can be a challenge with our administration, but, you know, we've got a number of examples where we've been able to get some investments in capital such as this, and it's really, you know, paid off in the long run, you know, not only in good outcomes for our patients, but, you know, what's the cost of caring for these patients, you know, if they've gotten the plasma and had a better outcome. I guess, you know, Eric showed us the length of stay was actually longer, perhaps, but that, you know, I think is not really what you intended. You know, obviously there's some other other factors that complicated that, but I think, you know, it's often hard for the lab to justify purchases of these things when the impact is outside the lab, and we have to, you know, build systems where we can look at cost avoidance and decreases in mortality and morbidity and so forth to really, you know, make a good complete story. So again, I think the teamwork is really key in terms of making these programs fly and showing really what the true benefit is to the institution, which I think here has been very significant.
And those are, yeah, the funding that was authorized, I'm sure, had some impact, but in the future, just going forward, there are a lot of fixed costs that went into standing up these programs, and some of those are sunk in costs because of equipment that was purchased and so forth. But
yeah, we were fortunate to have a very devoted team, and Tom led that, so that was terrific. And I think, you know, this success built more success as we've now gotten additional funding through Johns Hopkins and so forth. So again, it's sort of seed money. It's an investment to really, you know, launch an entire program, and that can be a challenge. But we were fortunate.
Absolutely. So it's a good example of where research can provide resources for patient care very directly in real time and improve access. So this brings us to the final discussion question, which is, what are the future translational research directions for convalescent plasma research and related topics of serological immune marker testing and so forth? And one of the things that I'll just hand this over to Dr. Collins and to others as well, but one of the issues that came up is many of the patients who have needed convalescent plasma treatments have had some hesitation to participate in it. Perhaps there might be issues around whether it's a clinical trial and whether or not people would like to do it. There might be other issues that have to do with cultural competency of how it's communicated, or language barriers and so forth. This seems like an opportunity to do a lot of careful work with community engagement, leveraging the Chicago Department of Public Health, some of the community organizations that our CTSAs have invested in developing to hear from patients and communities. But it seems like there's a major opportunity in that space to really get patient voices and have the right kind of communication that's multilingual and culturally competent as one area. And then there's the systems, the healthcare delivery science, to have some way for everyone to talk to each other. And if there's a glut of convalescent plasma in one part of town, to how can that be redistributed? It sounds like a lot of that happened because of a lot of good-natured leaders who were willing to help. But in a pandemic and a crisis, people may do things differently than they would when we're not in one. So how can we really develop healthcare delivery systems that are going to be nimble the next pandemic is an area of research too. So others, what are you thinking? Where does this work go next? This is outside my bailiwick in many ways, so I want to refer to your expertise.
Well, Sean, one of the things that we've been thinking about and trying to do here, I mean, there are so many questions that we still have about this disease, and again, we need to prepare ourselves for future pandemics because I have no doubt there won't be any. But you know, what can we do to position ourselves to make the most use of this when it quiets down and we all have a little bit more time to think? And so I think many institutions have put in place biobanking and data banking efforts, and that I think is what you were referring to with the CTSAs and so forth. You know, we've been banking not only the viral isolates for sequence analysis and whatever, but also banking human DNA and human plasma and serum. When we think about the lack of biomarkers and understanding the whole mechanism of what's going on when these patients are doing well, doing poorly, responding to plasma or not, I think, as Eric mentioned, the biomarkers would be very useful in terms of, further delineating who should get plasma, who shouldn't. But I think we're going to have to look at that a little bit retrospectively, and if we have the appropriate biomaterials and data and outcomes, perhaps that will allow us to, investigate that a little bit more fully. So we've been trying to put that away. I know other places are doing the same thing.
Thank you.
One of the things I would like to see happen is a standardization of therapy, so that we knew exactly how much antibody, the good antibody that we were actually given to each individual patient. It would be terrific that at some point in time we identified the best neutralizing antibody and actually able to create that artificially so that we could actually identify dose response curves to success and failure of therapy. And then we wouldn't be wondering whether a given patient just did get therapy that was ineffective or whether there was some host factor that prevented him from responding.
So a translational research question related to that would be, how to identify the duds in terms of plasma that is not that efficacious.
Right.
Is there funding? There must be some funding opportunities for that kind of work, certainly. But all right. Yeah. Other thoughts, Lucia, about future trends? I mean, you're in the midst of it now. Where's this work going?
I think right now I'm back to my full-time job of cutting open people and sewing them back together, but I basically try to enable the convalescent plasma donation, the samples to go to the scientists. Basically, I'm like the conduit. And so right now, like I mentioned, Patrick Wilson's lab is studying the antibody responses, looking at signatures that might be useful for vaccine development or therapeutic development, and also trying to understand more like B-cell memory and biology regarding those things. So I certainly think it was a great time to set up collaborations across institutions, across the city, and link up really translationally something that we're doing in the hospital with the scientists outside. Someone wants to make a comment.
Yeah. So if there are any other comments, we've had a lot of participants today. You can certainly introduce those now. We have a few minutes.
Like Giselle has a question or comment.
Yes. Go ahead. Just put that in the chat, and we can raise that. So. Okay. There's a comment. Yeah, what is the comment, Giselle? Go ahead and type that into the comments and we can raise that. All right. Well, so at any rate, Would like to, yeah.
Sean, one thing that I've heard from Peter Marks at the FDA, which I agree with strongly, is that as much as the expanded access program was sort of a sort of necessary evil given the expediency of things, it would be nice when the dust settles to design, the way he put it was a just add water multi-center randomized controlled trial protocol for convalescent plasma if another pandemic were to emerge. The idea being that from the get-go, you could have, control arm data, which we now recognize is one of the weaknesses of what we've been doing over the last few months. I don't know if Gazelle is going to be able to talk. I've been working with Gazelle, who's the PI at NorthShore, for the 2 outpatient.
Can you hear me? Can you hear me?
Now we can.
Oh, yes, we can. Very good.
Okay. So yes, thank you. So we're super excited about this study. We're super excited that NorthShore is one of the 15 centers across the country who is doing this clinical trial with Hopkins and the NIH and the DoD. But here we have this great treatment to offer people, and no one wants to do the study. So it's very frustrating that we talk to patients that are high risk, exposed, and COVID negative or COVID positive with symptoms, but you ask them, do you want to get the convalescent plasma to reduce the risk of progression to severe disease? And people don't want to be transfused. They don't want to be in a research study. They decline it. And some of these people have diabetes, metabolic syndrome, they're elderly, they have heart disease, they have lung disease, they have all sorts of risk factors. But because they're not feeling that sick at that time, because again, we're trying to enroll people that are ambulatory. Again, in the first study, they had a high risk exposure, but they're COVID negative. And the second part of the second arm of the clinical trial, so it's 001 and 004, 2 separate clinical trials. In the other one, they have symptoms and they have a positive test result, but again, they are still ambulatory. And when we're doing their initial visit, we talk to them, they'll have some loss of taste or smell, they'll have some shortness of breath, some fatigue. We do their initial CRP and it's 50, which is a risk factor, which correlates with IL-6 and correlates with severe respiratory disease, but they don't want to do this study. And so I'm really just, if we're talking about future translational research directions, we need to somehow engage the NorthShore community, physicians and patients to be a little interested in being in the study.
Thank you. So absolutely. So we have these 2 clinical trials at NorthShore that are underutilized, and that's a major opportunity not only to get the word out, but also to try to understand what are the barriers that people are refusing convalescent plasma. Is it worry about transfusion-related acute lung injury or circulatory overload? Are there other issues, fear of blood products? This seems very important. It's come up thematically across the talks today. So just overall, we're coming up to the end of our seminar today. I wanted to really thank everyone for an outstanding seminar and lectures. Very impressive that these institutions and others, I'm sure, across Chicagoland have stood up convalescent plasma programs in weeks' times. There's been a great sense of community, civic engagement, and ability to make this available to everyone. There are some health equity barriers. We don't completely understand some of the reasons why the morbidity is so much higher in some groups than others. And we have distribution of convalescent plasma that is uneven across the city, but there's some very promising, exciting results that have been presented on from serological immune testing to the very promising outcomes at Swedish and University of Chicago from patients. And there's still many opportunities for patients to receive this treatment through research. So I think this is a really important conversation we've been able to have today. And again, I'd like to thank Rabia Ali for administrating this Zoom seminar. We hope we could get as many comments from people as possible. And so feel free to follow up. There's some contact information here. You'll be sent a link to a survey evaluation at the end of this. And this will be available, will be recorded and made available to you as well. So thank you all very much. And stay safe. And we'll see you again next month.
Thank you.
Thank you.
Thank you.
Thank you.
Thanks, everyone. Bye-bye.